So you want to be sure that you review all of your classroom recordings and also the exam review links that will be provided inside of your announcement or shell. In the event that there is a question about any one concept, please be sure to reach out to your professor so that you can gain clarity. So with the nursing process, we need to be sure that we understand when we're talking about who does what, we're talking about the registered nurse and the licensed practical nurse. While the LPN is not an independent practitioner, but within the nursing process, there are two main parts that they function more independently. So just think about when you go in to do your clinicals. You're going to do your head to toe assessment, where you're going in to do your skills, administer those medications, when you're going in to do dressing changes, all those different skills. So the LPN gathers data independently during the assessment and also during the implementation phase. So what that means is the RN does not have to be on that person's side while they're actually in gathering that information. So from the information that we gather from the assessment, which is subjective and objective data, which we'll talk about that in a couple more slides. Subjective data, that's that information we get from the subject, the patient or the client. And then the objective data is that information that we gain. And that does include when we are assessing their level of consciousness and their orientation. So we're asking the client, can you tell me, who you are, where you are, date, your purpose for being here, those assessment findings, that information that that patient gives us, and we decide, okay, this person's oriented times one, two, or whatever it is, then that is objective data. But remember, again, we as the LPN, the RN does not have to be in at the bedside while we're gathering this data during the assessment phase and during the implementation phase. This is where we're carrying out, where we're actually doing the dressing change, where we are actually administering the medications, whatever that intervention is that we're implementing, that we're carrying out. And this slide just reinforces what we just said. The LPN functions in an independent role in the nursing process by collecting data, subjective and objective data, from a client and implementing interventions, carrying out those interventions. While the RN creates the nursing diagnosis, which comes from the NANDA list, the LPN collaborates with the registered nurse on the plan of care and evaluation of the client outcome. Okay. Safety is always going to be priority. So no matter what's going on with your clients, no matter if it's they're coming in because their electrolytes are off, they may be dehydrated, they're coming in, they have pneumonia, uh, mental health crisis, whatever it is, safety is always going to be priority. We want to make sure that those clients are safe, that they don't fall. We want to make sure that call lights are in reach, that pathways are clear, and that areas are well lit. Because remember, these clients are not in their home. So the environment is going to be unfamiliar. So safety is always going to be a priority. Before collaborating on the plan of care with the registered nurse, the LPN must assess the client's understanding first. So we do want to know what the client knows about their condition. We don't want to jump to judgment and say this client is non-compliant. And in fact, that the client may really not understand what hypertension is, what diabetes is, and what they need to do to actually manage those processes. So we do want to assess that client's understanding first. What does the client know their condition? What do they know that condition is, and what do they know to help manage it? What are those priorities for them to change or them to include in their own self-care? So then who does the patient teaching? So be careful with your words. We have initial teaching, and then we have reinforcement of teaching. So the RN does the initial teaching. So what other words mean initial? First, initial, and then reinforce is coming in after that first or that initial teaching has been done. Okay. And the LPNs can reinforce and collaborate with the registered nurse. So out of all the things that we do, the nursing is the most trusted profession that it is. And we do everything pretty much from A to Z. The United States Department of Vocational Education has summed it all up in 4 words. We do need to know these 4 words. And these 4 words describe all those things that we do that's in our scope of practice. That is to judge, recognize, determine, and appraise. We need to know those terms. So subjective and objective data, we kind of mentioned this for a few minutes ago. So the subject or the client or the patient, the resident, depends on what setting you're in, is what you call the actual person that we are taking care of. So that is the information that they will give us. We are asking them about their pain. The patient states, my pain is a 7. I feel nauseated. I am hungry. Those are the things that the patient is stating to us. And then the objective is that information that we are observing, using 4 of our 5 senses to gather that information. So for vital signs, we're looking at that dial, we're looking at that temperature probe, that reading, we're listening for that boom boom on the blood pressure, for that blood pressure measurement. So that skin turgor, we're pinching up and then watching that skin readily reform or not. We're observing the color of that skin, what that wound looks like. We're measuring the width, the depth, the height of that wound. And then like the example that I gave earlier is where we're asking these questions to determine whether or not this client, what their orientation level is and whether or not they are confused or oriented. And so this is objective. This is the information that we gather. We mentioned safety. So think about safety is a priority all the time, no matter what's going on with that client. If the client is lightheaded, dizzy, if that client is newly diagnosed hypertension, diabetes, post-op, if they're having respiratory difficulties, the client is dehydrated, no matter what that diagnosis, we need to be thinking about safety, safety, safety. What can we do? Is this client on fall precautions? Do we have personal belongings, cane walkers, crutches? Do we have these things in reach? Does the patient know how to use their call light? Is that call light in reach? So in the event that they are lightheaded, they're not feeling well, that they can ask for that assistance. In the event that they need assistance, how do we know that they need assistance at that time? That call light is in reach. That's their way of communicating with us. And then the other 2 examples we have here is we're putting into context. So like this patient is 3 hours post-op. So what are those things that we're going to be doing to keep this client from developing blood clots and so that they are as pain-free as possible? Well, they're going to be wearing those compression devices. We're going to make sure those things are intact. We more than likely will be administering some type of anticoagulant. We're going to be monitoring that pain. We're going to be going in, asking them what their level of pain is. We're going to be observing for those nonverbal cues as well. Is there any facial grimacing? Is there any moaning? And then, of course, their vital signs. For respiratory difficulties, we want to, a lot of times, just getting them repositioned. For some reason, they kind of get in that part of that bed where it's like a little slump there, and those lungs can expand like they need to. So repositioning that client, making sure the head of the bed is elevated. And then we want to try to prevent respiratory difficulties, them from developing pneumonia or anything like that. So we want to encourage them to use that essential spirometer to do those deep breathing exercises. But if we need oxygen therapy, we can, if we have that order, we can put that oxygen on that client. Safety is priority. Do you know the LPN will most often reinforce not do the initial teaching. The LPN will most often reinforce the client teaching and notice changes needed to the plan of care during the implementation phase. Remember, we are more independent practitioners doing that assessment and the carrying out or the implementation phase of the nursing process. Nursing interventions are patient specific. So we provide that unique, individualized care. We have 3 patients or 5 patients that all have hypertension. They're still going to receive that unique, individualized care plan that's specific to them, because one person might be hypertensive and they might be pregnant. One person may be newly diagnosed hypertensive. One person maybe have hypertension. They're coming in to get the hip replacement. That's why we're going to provide that individualized care. Even though they may have a diagnosis that is similar or the same, we still provide that specific individualized care for those clients. And we identify those, those individualized outcomes for them as well. Now, the electronic records, for the most part, when a facility purchases those products, when they get the care plan, all the options will be there. So it's up to us to know that, well, hey, we have to provide that individualized care for this client. So all those options that are listed, because they're part of that package that the facility bought, we know that not that every option will not apply for our client. Okay. So when we're looking at outcomes, they need to be measurable, realistic, and time specific. So when we are trying to decide or determine which outcome is better for our client, we need to look and see if it's measurable, if it's something realistic in this setting, and is it time specific. This client will be afebrile, within 8 hours. And then, how can we know? We're going to measure that temperature. Is that realistic? That medication that we're given, usually any antipyretic usually works within 4 hours, for sure, no more than 8. And then we put that time specific on there. So making sure if we're trying to decide which outcome is better for our clients, look and see, is it measurable? Does it make sense? Is it realistic? Is this something that really can happen? A person that has diabetes, we're looking at their glucose levels. What's more specific? That number, that glucose that is within range, is their diet, the number of calories that they consume within that 1,800 calorie that's recommended, and their glucose, are we checking it every 4 hours? So just make sure when you're trying to determine what's going to be the better outcome, look and see, do we have something that's measurable, realistic, and see if there's a time frame that's on there as well. All right, let's do a knowledge check. Which care plan will provide the most thorough, comprehensive care for the client? So we have individualized, standardized, generalized, or non-specific. And we just said we provide unique, individualized care for our clients. So it is individualized care plan. That standardized care plan, that generalized care plan, they're just going to have pretty much everything that's in that package that was purchased. But we want to go in, because we're talking about the client. So we want to make it specific to them. So we want to provide that individualized care plan. All right. Client-centered, relationship-centered care. We want to make sure that we're culturally competent. So what that means is we need to identify what we think and feel about culture, our own preferences. And then we need to find out more about the people that we're taking care of, and know that the things that they value and their cultural preferences are probably going to be different from ours. And it is okay. We're providing care for the patient because we want to include their preferences, their needs, as long as it's not causing us any harm or them any harm. We do want to include that in their the care that we're providing. We want to include their preferences in there. Open and closed communication. Which one will gain us more information? Which kind of communication will give us just to the point, for the most part, one answer? So close is to the point. Do you have pain? Yes or no? Are you hot or cold? I'm cold. I'm hot. Are you hungry? Yes or no? And that's closed. But if you ask an open-ended question, you're going to get more details, more in depth. And from that, you can ask a more focused question. So open is, can you describe your pain? So an example response might be, well, I have pain on my right leg, and it's more so toward the side when I step, when I'm running or when I'm walking. And it hurts all the time. It hurts sometimes. So with that open communication, you'll get more details, more details. And then you're able to ask and then focus in on what's really going on with your client or your patient. SBAR, it is a way of communicating that keeps us organized so we don't forget any information. Situation. Why are we calling? What is the reason for the call? And and so when we're calling that healthcare provider, we want to tell them who we are, what unit we're on, and of course the patient that we're talking about, and then what is the problem? Why did we call? Situations could be the patient failed, the patient is still complaining of pain, despite being administered pain medication. The next medication is not due until 2 more hours. It could be a new finding. A situation could be something that happened. We could have administered a wrong medication. The client could have fallen, but it's the why. Why are we calling? Then background. So remember, you're on the phone, so we have to give as much information so that that physician, that healthcare provider, can make an informed decision about what we're going to do for this client to assist them, to diagnose them, or either to manage whatever it is that they have going on. So they do need to know, well, what date did this patient get admitted? Why did they get admitted? Because our situation could be the reason or the why we're calling could be related to this admitting diagnosis, or it could be something totally different. And so then we can determine, well, okay, this is a new issue going on with our client, or this is something that's continuing. So we do want to give medications. For example, if we are calling about that temperature still being elevated or the blood pressure being elevated, high or low, we do want to let them know what medications they're on, because that will help them to determine whether or not what's the next step. Do they need to order more of this, another dose of that same medication, a different medication? And then allergies. They will need to know the allergies because they don't want to order something that will mean that the client can't take it and we're going to cause them harm. Hopefully, pharmacy will catch it. But if we already know the allergies, then the healthcare provider is not going to order that medication. So we do need to let them know what their allergies are, what medications, what foods and things that they cannot take, that they are allergic to, what IV fluids that they have, if it's HELP lock, and what is their code status? Are they a do not resuscitate? Are they a full code? And what do we think is going on with that client based on our assessment findings? Is this life-threatening? Do we think is this a change of level of care? And then the recommendation. What is it that we need to do to manage, to resolve the reason why we called? The recommendation. What is it? It's the goals of care. What do we need to do to resolve or to assist with managing the reason why we call? So this can be a new medication order. It could be labs need to be drawn. This patient may need to be transferred out of the facility or within the facility to a different level of care. So the recommendations, these are things that are going to help resolve or manage the reason why we call. Okay. And when we're doing, we can use Aspire also to change shift, because remember, healthcare facilities, unless you're in like an urgent care center, care is ongoing. So at some point we leave and go home and the next nurse comes on. So we need to give that nurse information, because that helps establishes their baseline. It allows them to know what has been going on with that client. And so we tell them that pretty much the same, the situation, which is change of shift. You know, how long were they there? What was their admission date? Why did they come in? What was their chief complaint? And we give that background information. We give things that's been going on since we have taken care of that client. And that will include our vital signs, our pain assessment findings, and any new orders or anything like that. And then the recommendation, what else? I'm going home and you're coming on. So the finger stick is due in an hour. So those things that need to be done, because we provide that continuity of care. Care continues on. So that next shift, that next nurse needs to know what needs to be done next for this client. And if they have any discharge needs or anything. Active listening, the most important part of communication, particularly therapeutic health related communication. It is that interaction between the sender and the receiver. Just making sure we're still recording. The sender and the receiver. And we want to verify and ensure that the information that is being sent is actually what the receiver actually received. Because there's sometimes a person will say something or state something, and what the receiver understood or interpreted was really not the message that they were trying to convey. So these are some active listening techniques to verify and ensure that the information that we as that nurse that on the receiving end from our client, we can make sure that we understand what they're trying to tell us. Now, this remaining silent is one that, we're all the time trying to, do something, but sometimes doing something is just being present and remaining silent. It is okay. If the patient or the family members are not ready to make decisions at that time, just being present, letting them know that you are available, remaining silent is therapeutic. It is active listening. So restating is repeating what they said in a different way. Clarifying, we want to ask questions in a response to the statement the patient made, just to make sure we understood what they said. Reflecting, putting into words the information that we received from the patient at an effective communication level, repeating it back, but put it into words, that are plain, simple, easy to understand. Paraphrasing, we're expressing what they said, but we're putting it into our words. We're telling them back, we're expressing it back in our own words. And then minimum encouraging are those sounds and those gestures that we do. Keep going, or we may make those hand gestures that indicate the patient should continue talking to us. We want to let them talk uninterrupted, but we do want them to continue. So those head motions, those gestures mean go ahead and finish and continue to talk. Summarize, stating that main idea that we have gathered. That's a summary of all the things that they told us. And we just, do a summary of it. And then validating allows the patient to correct information when we summarize it. It allows that patient to go back and say, hey, yes, that's what I was talking about. Or they may say, no, I was talking about when I put my foot like this, when I actually when I bear all my weight on my foot, not when I'm just running. So it allows the patient to correct any information that we have summarized that may or may not be correct. And they verify that it is correct or not. Okay, so let's look back again at clarifying, restating, and paraphrasing. So we have some examples here. These are the three that I think we want to make sure that You really do understand. The other ones, I think we pretty much have it. So we pulled these three out because these are the ones that we kind of get confused or mixed up the most. So clarifying, asking a closed-ended question in response to the patient's statement to be sure that we understand. Okay. So the patient says their chest hurt. And here's the nurse. Now tell me exactly where your chest hurts. So we're clarifying that they're actually saying that that's their chest, not their leg or their stomach or their arm. So in the event that the client meant some other place, when we clarify this, they can correct us. So tell me exactly where your chest hurt. And also, this is a more focused question because, is it the right side, is it the middle, or is it the left side? Restating, repeating what the patient said in a slightly different way. The patient states, my chest hurts and I can't sleep at night. So here we have the nurse's response. You have been unable to sleep at night because your chest hurts. So they said two things, but we're restating just to make sure that to verify that this client, this patient is saying that they can't sleep because of their chest hurting. Is that the reason why they can't sleep? Or are those two separate things that they're trying to tell us? Okay, then paraphrasing, expressing in our own words what you think the patient means. Okay, we have the patient saying, I don't think I am being told the truth about my condition. And the nurse replies, you believe you have not received all the important information about your health condition. So then, we're putting it into our own words, but not changing what they actually have said. And again, all of these active listening techniques allows us to make sure that the information that we have received as that receiver is actually correct, because then we're going to respond based on what they're saying. So positive communication techniques, again, like I said, we want to develop that trust, that openness with our clients. We want to be honest with them. We want them to be honest with us. Using I messages, establishing eye contact, not sustained eye contact, and not glaring eyes. So establishing eye contact, looking away, making that eye contact here and there is positive. We want to keep our promises. So if we're saying we will be back to check that temperature in 4 hours, we need to return. And or if not, if that's something we can delegate, we want to make sure that we do what we are telling them that we're going to do. Express empathy. We want to use open communication and be aware of our body language. If we're doing that dressing change and that wound has an odor, we may have gotten that information as we were doing handoff. So when we go in and as before we do that dressing change, we facilities for the most part will have some type of procedure that if it's opening the window, getting that fresh air, or if it's some type of deodorizer that can be placed in the room while that dressing change is being done. Just make sure that we are being aware of our body language, facial grimacing, make sure we're not frowning, closed arms, folded arms, and things like that. We want to make sure that we are our body language is open, and receiving. Factors that may affect communication. So age, gender, income, life experiences. And think about if you're going in and your client, we are trying to assess their pain. We're trying to do a head-to-toe assessment. A lot of times in these settings, hospital settings, and even in the long-term care settings, there are alarms going off. They're in an unfamiliar environment. They may have a roommate that's watching TV or that's something's going on with that roommate, and they can't focus on what your purpose of being there. So that situation, that environment actually can negatively influence their communication with you. It may block communication. And we talked about doing that dressing change. That's a situation where it can affect communication. Any distractions. Negative communication. So a lot of times we struggle with this one, giving advice, because our clients, once we've established those therapeutic relationships with our clients, they trust us, we're being open, honest, they are being the same. And they kind of say, well, what would you do, nurse? But remember, we do not give advice. We want to make sure that that client has enough information so that they can make an informed decision. And we support them in whatever that decision is. We support their autonomy. So it's actually negative for us to give advice. We don't want to be probing and asking questions like, okay, you know, how did you get that type of insurance, or things like that, or trying to ask or asking questions that has nothing to do with the care that we're providing. We don't want to make judgment statements. Okay, well, the patient is coming in to have a certain procedure done, but this client must have, not been taking their medication like they're supposed to. This client must have not been eating correctly. All of these things are considered negative, but they're giving advice and they don't mean anything by it, because like I said, you've established that relationship with them, but we want to give it back to them. We want to support them in whatever decision they make. So we have assertive, non-assertive. So non-assertive is considered as being passive or passing the buck. And then assertive is the opposite. It is being open and honest. And then we have aggressive. That response, or our responses to our patients. Aggressive is being negative, abrasive. Now we can be open and honest and to the point, and be assertive with that. We don't have to. We can tell them what they need to know. We don't have to break any rules. We can remind them what the policy procedures is, and in an open and honest way, without having to be aggressive. Okay. Let's look at these. Which style would be used to advocate for the patient? And remember, we're talking about non-assertive, aggressive, and assertive. Which style would pass the buck? And which style would be confrontational? Okay, assertive being open and honest, and we're advocating for that client. That client's pain medication. They take the medication, they're completely zonked out. That client cannot, they're not in pain, but they cannot even function at their norm. So a phone call is made. We advocate, informing that healthcare provider of our findings. We question, we let them know what's going on with that client. So hopefully they more than likely will change that order. That pain medication may need to be changed, or that dose may need to be decreased. Passing the buck, that's passive or non-assertive. And then confrontational is being aggressive. Even if the client wants to leave against medical advice, it's their right to. We make sure that client knows, well, hey, this is against what the medical advice is. In the event that you want to, we will notify the appropriate people and complete the appropriate forms. We don't want to be aggressive and hold them there and, be mad at them because they're leaving against what's recommended. We want to consider workplace violence. So things that we need to think about no matter what setting we're in. What conditions are our patients in? If it's a client that has had a head injury, if they're going through a mental health crisis, if that client has Alzheimer's, even if the client has diabetes and they're having a crisis, their mental status is going to be altered. And as a result of that, clients may be combative, they may refuse care, and we need to be careful because the nurse might get injured because that client is not understanding the care that we want to provide for them. And because they're, not in their right state of mind. So they may think that we're trying to harm them instead. So we do want to consider what conditions our clients are in. And also, a lot of facilities might not have security on staff 24 hours. And then what is the location of that facility? Most of the times, if you work at a facility, you don't park up close. That's safe for the customers. So usually staff has to park far off. And so what is that location? What is that pathway? Is it well lit? We want to consider all of that because things do happen. And so we want to think about our safety. We just talked about safety first. So we're going to think about our safety as well. Sexual harassment. The first thing that we want to do, if we are the target of it, we want to confront that person who's harassing us and tell them no, Be assertive, straight to the point, and honest. That whatever behavior is offensive and is unwanted. Make sure that we're being firm, and make sure that what we're saying and our verbal and nonverbal communications all say the same thing. We're saying no, but then we're smiling and laughing, and that's sending a different message. So we want to make sure that our verbal and our nonverbal are sending the same message. Okay. All right. Cultural skills. We talked about being culturally competent. We want to be aware of our own culture preferences, and then know that, our clients, they might be different from ours, and it is okay. We are providing the care for them, and we want to gain as much knowledge and understanding about what their preferences are and the things that they value. We want to include that in their care, just as long as it does not harm us or them. Okay. Enculturation, process of learning your culture, the way the group does things. Okay. Areas to consider: client preferences, their needs and values. Communication: the client and nurse may speak different languages. That eye contact. Sometimes some cultures, eye contact is offensive. So this establishing that therapeutic relationship with our clients and talking to them, we will find out these things, whether or not if touch is appropriate or not, if that space, if we need to, be up close and personal, or we need to make sure that we honor their personal space. Food preferences, that we need to bring in that dietitian if there's anything that's going on with that food, whether or not it's the meal options, those food items, if it's the time the meals are, because for the most part, facilities have these set times and they do have these set meals, but they always have an alternate. And we want to bring that dietitian in. We want to make them aware of what our client preferences are. And so that can be incorporated in their plan of care. We don't want our clients not to eat because what's on the menu that's already pre-made is something that they don't eat. That's not acceptable. So negative effects on culture, ethnocentrism, thinking that person thinks that they're whatever way that they think is the only way, is superior to all the other ways. Stereotyping, we don't want to make assumptions and be putting everyone into one group. Prejudice, intolerance of another culture. Discrimination, withholding rights and privileges of another cultural group. We want to treat all our patients the same, no matter if we know that this client is hypertensive and they're non-compliant. If this client comes in and they're diabetic and they're non-compliant, this client comes in and don't have insurance or might not have enough insurance, we still provide that best care for all of our clients. Okay. The interprofessional healthcare team, there's so many of us. Usually that nurse is going to be that center point. And so we're going to be the ones that everyone's pretty much is going to be coming to when they have questions or concerns, and if they're trying to find out information. But all of us have that same goal, getting that client back to that optimal level of care. And so it will take working with others, establishing those relationships within that care team. And on that team, we have a physician, or we say healthcare provider, that dietitian. We just talked about bringing them in. Anything has to do with those meals, whether it's the time of the meal, the food items. We want to bring them in. They're part of that team. That social worker, they find out and seek out. They already know all those resources that are available, and they can make those connections if that client is getting ready to be discharged. The client may need a hospital bed. They may even need a cane walker or crutch. They may need their medications delivered to them. The social workers, they know about all those resources. Well, we know discharge begins on admission. We need to start thinking about it, because those patients are not coming to those hospitals to stay. And so we want to work with all the people on the team, especially if the client is needing, respiratory therapy. They're needing occupational therapy and physical therapy. They're just had that hip replacement. They're needing to know how to drive again. Not really that the therapist is going to get them in a car, but they have activities that they can do in those therapy rooms or at the bedside that gets those patients back moving with all those movements that are required to open that door, to walk up the stairs, to walk and things like that. So, but it takes all of us coming together to provide that optimal care for our clients. It is important for the nurse to accept the client's right to their belief, neither agree nor disagree with their choice, and respect their right to refuse treatment or medication. We don't want to try to change their mind, but we make sure they have all the information that they need. They want to leave against medical advice, make sure that they have all the information they need, complete the forms, and we don't agree or disagree with it. We're just, that client's decision is their decision. If the client asks you to pray with them or perform a baptism, we can do that. Especially if death is imminent, is usually when the client or family member may ask, particularly the client will ask, that to be done. Some clients may, if death is imminent, we may not have time to go get a person of faith. So we're there. We can do that. Some clients may belong to a religion that does not believe in certain medical treatments. Never assume what a client's choice will be. We still offer them the choice and let them make the decision. And because we do know that while beliefs and cultures, they're passed down from generation to generation, but sometimes that person may not endure or value all those things have been passed down. So we always offer them the choice. We let them make the decision. Clients may have different food preferences or times to eat. We want to utilize the appropriate healthcare team member, which we just said, the dietitian, to come in and assist us. Remember to have a dry erase board or that clear sheet protector. A sheet of paper will not be used, can't not be used. Make sure you do the practice exam to make sure that your computer has the specifications. The exams are usually ready for download an hour prior to the exam. So therefore, you can go in and download it, and that's ready. Make sure that you have your identifications. In the event that you're needing that exam proctored on campus, send an email requesting that from your campus dean. In the email, be sure to include your campus dean, Dean Darlene Brown, the course lead, which is Dr. Tenza, and whomever your course professor is, so that the appropriate time and place can be set up for you. Okay, I'm going to pause. Are there any questions?
No, ma'am. Thank you so very much. I appreciate you.
You're welcome. Take care.
Have a good evening.